Hello, everyone. Thank you for joining us today. I'm Lynn Stevens with the Ohio Grandparent Kinship Coalition. I'm one of our co-presidents. We're happy to have you here today to join us for some great information to be shared by our speakers today. I just want to acknowledge our other officers who are part of our coalition. Um, Ms. Brenda could not be here today. She's feeling ill, co-president. I always forget her last name. I am so sorry. Siobhan Jones, our co-vice president. I'm not sure she's joining us today. And Ms. Jones, our co-secretary, Ms. longtime board member, Ms. Barbara Turpin, board president, Ron, um, as well. So thank you for being here. Our topic today was fetal alcohol syndrome disorder. Caregivers, if you would like to be put into a drawing for a $50 gift card, please feel free to do so. Put your name in the chat, your email address, and your name in the chat. And at the conclusion of the webinar, we'll be able to announce who has won the $50 gift card. Include your county as well. So your name, your email address, and your county of residence, please. If you're an agency, please put the name of your agency and a county of residence in the chat as well. A link to an online evaluation for the presenters will be provided during the presentation for all to complete. Please complete it within a week if you can. Appreciate that very much. Your input would be greatly appreciated. Our next meeting is March 17th, just FYI, on the WIC program, Women, Infants, and Children's program. And lastly, also, if anyone would like a certificate of attendance for attending today's webinar, please indicate that as well in the chat, your name again, email address, and Ms. Barb Turpin will send you a certificate. So our presenter today is, let's see, Goki Ergun is a clinical, is a clinical faculty and licensed, clinical psychologist in the state of Ohio and a former associate professor at the School of Professional Psychology at Wright State University in Dayton, Ohio area. She is a grant recipient from the Ohio Department of Mental Health and Addiction to promote screening, diagnosis, and treatment of fetal alcohol syndrome, spectrum disorder, and Dr. Ergun has a bachelor's degree in psychology and a master's degree in clinical psychology from Boğaziçi University in Istanbul, Turkey. Excuse me for mispronouncing that. Dr. Ergun has extensive training and experience in assessment of neurodevelopmental disabilities, specifically fetal alcohol spectrum disorders. She has conducted numerous fetal alcohol syndrome spectrum disorder evaluations. She sat in IEP meetings to advocate for families and children impacted by FASD and provided consultation to families. Dr. Ergun also provides several trainings to mental health agencies, trains staff at various organizations in the areas of indemnification, screening, diagnosis, treatment, and prevention of fetal alcohol spectrum disorder. She's also a member of the American Psychologists Association and National Association of School Psychologists. So with that, I'll present and turn it over to Dr. Ergun for her presentation. We greatly appreciate you being here today. Thank you.
Thank you very much. Welcome, everyone. And I'm really happy to be back here. And I know in my first presentation, my first round, I talked about the red flags, the symptoms, and kind of like some very basic interventions for individuals with fetal alcohol spectrum disorders. And I'm hoping that some of you were able to attend that, or you have attended other presentations where you are familiar with with the symptoms, the red flags, and kind of like the basic struggles and the difficulties that individuals with FASD face, both from lived experience as well as being a caregiver and or being in a treatment role if you hold any of those roles. So, today I'd like to talk a little bit about more in depth and then about some of the treatment options that are out there. And that will also be followed by talking about one particular treatment modality and an approach that I'd like to discuss with you in a little bit more detail, and hoping that that is maybe something that can be implemented either in your practices or in home. So, first of all, I wanted to start out with what are some of the things that we need to factor in and understand in terms of some of those variables that will change treatment outcomes. So, if an individual has, of course, intellectual disability, meaning that an IQ below 70, and I'm sorry, IQ above 70. So meaning that they do not have, intellectual disability. And also if the individual has a diagnosis of what we call ARND or partial FAS, which is alcohol-related neurodevelopmental disorder or partial fetal alcohol syndrome, which are kind of like the less severe forms of fetal alcohol syndrome. So if an individual has these and less of the language impairments, so that means that there are less barriers, so our treatment gains will be higher. Um, any intervention that I'll talk about today, they need to target the entire spectrum. So we cannot just really focus on just behavioral issues, for example. We need to focus on all of the different areas that are impacted by FASD, which I'll talk about in the next slide. And the interventions need to include not only the clients, our clients, which mean our children or teens or the young adults with FASD, but also they need to include parents, foster parents, kinship, caregivers, adoptive parents, birth parents. So we need to work with the entire family. It's a family systems approach. And the interventions need to build on providing support to the family, providing lots of psychoeducation, giving them knowledge, and equipping them with lots of different skills so that this is something sustainable for life. It is not just a one-shot type of treatment. Most of the effective interventions in general, they provide, first of all, behavioral management, because we know that our children with or individuals with FASD have a lot of what we call behavioral dysregulation. And because of that, it is a brain-based disorder, and these behaviors are not willful. However, they still struggle with the ups and downs, changing the moods very quickly, and engaging in sometimes what we call aggressive behaviors, non-compliance, and difficulty following directions, then we definitely need to teach them, teach families and parents behavioral management skills. So that's very important. But that's not where we are done. So and then we need to move on teaching then parents skills as to how to handle their children, how to discipline, how to manage the difficult behaviors, so aka the parenting skills. Then we need to give some information on stigma, because this is a highly stigmatizing diagnosis where, especially for the birth parents, but also for caregivers, kinship, and any providers, having a child and or individual with FASD carries a lot of stigma with that. So how to deal with that, how to cope with the difficulties that comes around it. We need to provide information on substance abuse, because what we know is that 70% of the individuals with FASD, they do have ADHD. And when individuals have ADHD, they are more prone to engaging in substance abuse for coping, as a coping mechanism. And due to the impulsivity and difficulties with decision making, then these behaviors can be more risky. So we need to provide information and screen readily on substance use. We need to aim to decrease the primary symptoms, but also we need to make sure that we're dealing with the secondary symptoms too, which are other mental health issues such as anxiety, depression, substance use, school dropout, difficulties finding work and housing, and all of those other things that come secondary to the primary symptoms. And we need to provide resources, education, training, and direct services also to caregivers. So, having said that, I think I made that very clear that we need to work with the entire system. While we try to maximize adjustments to having a child with FASD at home, we need to also work on decreasing parenting stress because parenting a child with FASD can be extremely stressful because of the multitude of the challenges that an individual with FASD faces. Therefore, a parent or a caregiver with FASD faces. So when we think about FASD treatments in general, we have to make sure that we provide educational treatments, meaning that we need to do something at school that's different. So that could be in the form of Section 504, or that can be in the form of IEP, but providing special education services, even though the child's IQ might be within the average range, they learn differently, period. So therefore, they will not benefit from the same educational interventions or methods to teach. Therefore, we need to advocate for our children to have individualized education plans and programs so that we can support them at school, not just behaviorally, but also educationally by teaching them, providing the information in a different way that will make sense in their head, and that information that they will able to learn and memorize and keep in mind and digest. The FASD treatments will need to focus on cognitive part too, because our children with FASD, they learn differently. Their attention level is low. Sometimes they have language barriers. Their memory is compromised, and I've talked about this extensively in my first presentation. So they have a lot of difficulties transforming what they have learned into long-term memory, and they also struggle with how much they can learn one at a time, which we call encoding. So if the school is not aware of these, then they can try to load a lot of information, and then our children will just have a tantrum, they will have a meltdown, they will stop paying attention because it's just too much information and it's too overstimulating. So we need to understand their cognitive style so that we can teach them differently. Also, FASD treatments need to focus on parenting skills, provide behavioral consultation, and case management. We also need to teach very early on social skills because our children with FASD, they also struggle a lot with a lot of like a variety of social skills, going from not having stranger danger, um, and making friends with individuals who may not be safe, and not being able to judge those situations really well. So they might put themselves into situations where they might be taken advantage of by others, even their peers. Therefore, those social skills and safety skills are really, really important, and they need to be at the forefront of any treatment pretty early on. And then finally, medication management and medical care. Because individuals with FASD, because of the brain differences, because of the early damage that happens in the brain, they are susceptible to many different medical issues as well. So frequently having, doctor visits, regular pediatrician visits, yearly visits for both, well visits, as well as if there is any kind of issue, and working with a psychiatrist, just making sure that their mental health is in good condition is really, really crucial. So as you can see on this chart here, there are many areas that gets impacted by prenatal alcohol exposure. So therefore, when we work with the family and when we provide treatment, we need to make sure that we attend to all of these areas. So, and you might say, like Dr. Ergun, these are a lot of areas. How can we attend to all of them? Yes, I do understand that. And that's why FASD treatment is not like this easy. It's not a one shot thing. and it is not a short amount of time, as you will see in the upcoming treatment modalities. So in 2009, there was this whole number of research that was done to come up with evidence-based modalities and evidence-based treatments for FASD. And then they came up with 5, and I'm going to be talking very briefly about 4. And today I'd like to introduce you to the last one, which is the PACT program, or what we call the cognitive habilitation. And these are all evidence-based programs. So all of these evidence-based programs include parent training and education. They always include parents as agents of change. No FASD treatment will be complete without involving caregivers and parents. Always using community resources and always providing explicit instruction. And I'll tell you what that means. So the first one, maybe this is something that you might have heard before. Maybe some of you are already able to provide this treatment, but this is called Families Moving Forward, that originated in Seattle at the University of Washington at the FASD clinic in the beginnings of the 2000s. And this is a behavioral consultation that is tailored for families who are raising children with FASD, and the ages are 3 to 13. So as you can see, this can be done at home. So the clinician comes to the home, like home visit, or this can be conducted in the clinic as well. This is 14 to 16 session, and then each of them is like around 60 or 90-minute sessions. And this is not a one-time shot thing. So we said, yes, 16 session, but then it kind of like runs another round. So this is to make sure that the families, the caregivers learn thoroughly how to handle the children's, behaviors, how to teach them different skills. And this is more like a consultation model where once they learn the skills, those are repeated over time so that it is learned really, really well. And then the parents feel really confident to implement it over a long period of time. So how does it work? First of all, there is motivational interviewing just to make sure that our parents, who are probably struggling a lot with many challenges of FASD, they are at the right time and right place to learn about this treatment. Which we can achieve by using motivational interviewing, which is a technique where you bring in awareness and then you try to bring in the change, and then making sure that the families are ready to change their methods, ready to change to learn how to deal with some of these challenges. Another one is positive behavioral support. This is where the clinicians work on behavioral consultation and then teach different behavioral strategies. Then we provide cognitive behavioral therapy for caregivers, and there's a lot of psychoeducation and support. As I last checked, as of today, it used to be with a lot of fee, but now, as I see, there is one that's going to happen in February and March, but the deadline was passed around in October. So it will be really important to check their website. It is free now, and it used to be like you needed to go to University of Washington, like the Seattle area, and do it in person. Now it's offered online as well, and it's free. So that's a wonderful opportunity for those of you who might want to maybe have masters at least, because I think that's the requirement, masters or above, who would like to learn this treatment so they can be trained a trainer in that sense. So this, I think, is a wonderful opportunity, and it is an evidence-based program, and it has shown a lot of efficacy because it provides the treatment and then it follows up the individuals for a really long time, which is like over a year, just making sure that the providers are able to learn what they're supposed to do, and then they can actually keep it up and maintain. So this is different than our traditional treatment modalities where maybe you go to therapy for, I don't know, 5 months, 3 months, 4 months, and then after that you're on your own, and maybe you're still struggling with implementing the treatment. Another treatment modality, maybe you might have heard it in behavioral issues like severe behavioral problems, is parent child interaction therapy, PCIT. PCIT is originally created for severe behavioral problems. Now, this has been adapted to use for FASD because FASD, individuals with FASD also have severe behavioral problems. So these are 90-minute weekly sessions. Again, as you can see, 14 weeks. This is not a short amount of time with parent and child. And the focus on just behaviors. Followed by practice in the session with in vivo coaching. When we say in vivo coaching, you teach the skills and then you put earbuds and then you go on to the one-way mirror and then the therapist or the clinician kind of gives feedback as to like, yes, this is what you were supposed to do. Now, please say this, and then this is how you can handle the behavior. So they can actually do it right then and there with getting live feedback about how they can change their parenting style so that they can prevent some of those behavioral issues. So significant improvement was found in decreasing children's behavioral problems, and this is also very helpful. One thing that I'd like to say about this one is that this needs to be done in a clinic, and in a clinic where there is a setup for one-way mirror, and then the psychologist or the therapist has to be trained in PCIT. So this is a little bit more specific than maybe the other one. And then the parent focus interventions are in this one, just the parents learn about parenting strategies. This is a cost effective method because it really focuses on parenting stress. And in many of the treatment modalities, yes, we work with the parents or caregivers. However, we really don't always consider how much stress the parents are under, and we don't really always focus on mending the relationship that has been maybe shattered by the challenges of FASD. So this is a program that focuses more on mending that relationship between a parent and a child, right? That attachment piece, and then making sure that the parents are not as stressed because of all of the load that they are experiencing for parenting a child with FASD. So this one has a little bit more of a different focus, which I think is really, really meaningful as well. In terms of social skills, remember we talked about that the children with FASD have difficulties with getting social cues, communicating in different social contexts. So there is a program called, and you can also research about this too, it's called Children's Friendship Training. It's a group activity. And there we teach specifically pro-social social skills. So we talk about being accepted as they are. We don't really talk about like all the things that they experience because of bullying or being rejected, but like what does it mean to be themselves? And what does it mean to be accepted? What does it mean to accept other people in their circle? So we teach them the behaviors, then we model it, then we rehearse it, and then we help them practice it right there in the session with the other members of the group. So and then we ask the parents to help us outside of class so that they can actually use these skills like in their day-to-day life when they have a play date or other things. So research showed that children with FASD showed good improvements in their knowledge of appropriate social behavior, and actually their social skills were rated higher by their parents after implementing this program. As I mentioned before, we need to teach safety skills to our children starting as low as 4 to 5 years of age, and maybe even before. So I'm sure a lot of you have had a lot of concerns about safety for your child, like not having that sense of fear, just doing something and not knowing the impact of it, not having that cause and effect relationship. Oh, if I get out of the home and walk because that's what I want to, then I'll be lost. Not having that understanding, although they might have intact IQ, like they don't have any cognitive issues, this is sometimes something that does not readily click in their minds. So it's really important to teach about fire safety, stranger danger, and about sexual issues too. Um, just making sure that they start learning about these early on. It doesn't have to be anything specific. Any safety skill program would be helpful. But what I'd like to emphasize is that let's not wait. Even some of the sexual issues, let's not wait till it's really late. Because a lot of our teens with FASD, they get into some difficult situations where they don't really understand the meaning of that. Some of the interactions, and then they can become like more sexualized behaviors, and they might just invade the space of others, or they might not understand, like when someone interacts with them, that this is something that they're not supposed to do, because it could mean that it has a sexual intent. So not being able to understand that intent behind things. So there are some programs that are computer-based interventions, and we know that children like computers, and some video games and things like that. So there are some that improves fire and street safety skills, which are the basic things to start out with. And as they age and maybe come into elementary years, we can add some of the trainings about sexual, like safe, like what's a safe touch, what are differences, between the genders and things like that, understanding body parts and so forth, and what is not to do and what is to do when we want to talk about these things, so that others don't feel, offended or get into trouble. And the last one I think is the educational interventions. Children with FASD, as I mentioned, they have a lot of challenges, especially in the area of comprehension. They have reading comprehension, written expression challenges at school, and they also have a different way to learn. So we need to make sure that they can get some support. One area that they specifically struggle is math. A lot of the children have math specific learning disability. And because of that, they have difficulty learning numbers. They have difficulty learning mathematical concepts, like which is higher, lower, which is more, less, and maybe some of the signs and things like that. So there are specific programs that just focus on math training. But even if we cannot do something like that, just understanding that children with FASD will probably struggle more in math than other classes because of that conceptual difficulty for abstract concepts. So any kind of support in the form of, it could be tutoring, or it could be like a group work at school, would be really helpful. And then some children with FASD, I would say most need to have an either Section 504 or IEP, and they would qualify under other health impaired category, and where we can keep advocating for them in the school environment, and then we can also teach them to advocate for themselves. The last couple treatments are in the area of cognitive. Remember, we had that wheel, and now we're kind of like going around the wheel and talking about the different types of treatments. One is a cognitive control therapy, CCT. This was also found to be evidence-based. As you can see, these treatments are again long, and the reason why they are long is that our children with FASD, they have a brain-based disorder. What that means is that some parts of the brain have been compromised because of exposure to alcohol in utero. And because of that, we cannot mend or we cannot create new connections in the brain over a couple months. That's not really possible. So we need a lot of repetition. We need a lot of going over and over and over. And that's why the length of the programs that I'm talking about are long, as opposed to some maybe other programs that you might have seen. So the cognitive control therapy really teaches them how to position their body, how to engage in movements, and how to have more self-awareness. Maybe those of you who have children with FASD or who have worked with children with FASD know that they have some difficulties with understanding where their body starts and where their body ends. So they might be like maybe clumsy, hitting others, but they don't do it on purpose, but they just don't have a good self-awareness of their body position. or body movements. So that's one thing that they start working on. Another one is what we call focal attention, because again, a lot of the children with FASD have attentional issues. They also struggle with scanning the environment. They have hard time finding things in their environment. When we want them like, oh, go grab your jacket, they were like, where is my jacket? It's right there on the bed. Like, where on the bed? I can't find it. So difficulties with scanning the environment and then knowing what task to do first. So prioritizing information, prioritizing tasks. So those are things that we can teach them. And then a third one is processing information in the presence of distractive stimuli. What that means is like they have hard time finding things in chaos. That's why home environment is really important. We can strive and hope that the home environment is structured, it is neat and not as cluttered, because they really struggle in finding things in chaos. That's what it means. So but we can teach them how to process information when there are a lot of chaotic things around and when there are a lot of distractions, but that's a struggle for them. And then they also struggle with categorizing information. They hear the information, but because they can't put it in a category in their mind, then when they need to retrieve and remember the information, they cannot pull it from the appropriate category. So if we don't store the information in a way where we categorize the information, that information will be so haphazard. So when the time comes for them to remember, they'll probably say, I don't know, I don't remember it. But they actually learned it. It's just that they haven't stored the information in a way that makes sense to their head. So those are some of the strategies that we can always use in our treatments as well. And our children with FASD also struggle with what we call working memory. Working memory is something like this. So I want all of you to recite inside your phone number. So I'll give you a second to do that in your head. Okay. Now, I would like you to say in your head, or you can try to say it out loud because we don't hear you. Um, I would like you to say your phone number backwards. So, um, I know I cannot see chat, but I just wanted to see like if saying your phone number backwards was more challenging than being able to say it forward. And most of the time, the answer is yes. And this is what we call working memory. We need to keep the information in our head and then do something with it. And most of the time, when we sit in lectures, when we are in school, when you're in a training like this, somebody is giving instructions or somebody is lecturing at you or talking to you, right? So we have to keep the information in our head, and then we need to maneuver it, we need to use it, and then do something with that information, right? We need to write it down, take notes so we don't forget it. So this is what we call working memory. So what we know is that children with FASD, they have working memory deficits. And therefore, they really struggle with keeping things in their mind. And hence, when you ask something from them, they'll probably say, I don't know. And then you might say, I just told you that. So, one thing is that we can ask them to say a list of items, and then we can ask them to recall the items at a later time. So, we can give them a short list, like of 3, 4 things. And then we tell them, now I want you to say it out loud. And after that, I want you to remember this. But so that you don't forget it, I want you to whisper the items, okay? After I tell them to you. So if we say like 3 things, for example, cup, apple, cat. Okay, so I want you to remember this afterwards. So you say like cup, apple, cat, cup, apple, cat. So we just kind of like whisper it to ourselves, almost in a way to kind of like help us with the memorization part of it. So once they do it, 4 or 5 times, then we can say like, now I want you to write it down. So writing things down in notes and sticky notes and things like that, that's also shown to improve memory skills, working memory skills. So we kind of like give them some type of strategy to help out with their working memory that is not well developed. So I would like to pause here, and because now I'm going to move on to our evidence-based treatment that I'm going to talk more in detail about. Now I'm going to tell you about the whole curriculum, and then what it's for and how it can be utilized and things like that. So before I get into that part, I wanted to give you information about the other evidence-based treatments for FASD in a more summary mode. But I wanted to see what questions we might have. And I would need help with that one because I cannot see the chat.
Has anybody that's on the meeting, have you had experiences with any of the treatment modalities that Dr. Ergun has talked about up till now? Or any treatment modalities, any kind of treatment that you've had if you do have a child with FASD?
Mm-hmm.
One of the agencies that has a support group for caregivers, Laverne Dotson here in the Columbus area, says that she has she's going to give this information to family in her group. So hopefully it will help support them in their ability to help the child in their care. That's good. Thank you, Laverne.
Thank you. That's wonderful. Yeah. One thing that I wanted to mention about FASD treatments is that we have treatments for trauma, we have treatments for oppositional defiant disorders, ADHD, autism, right? Like things like ABA and things like that. And a lot of these treatments, or for depression or anxiety, right? A lot of these treatments are readily and widely available for clinicians to learn, as well as we know anywhere people can go, they can get these under mental health facilities, clinics, hospitals, and so forth. One thing that is a little unfortunate about FASD is that the FASD treatments are not readily available, and and then being trained for these specifically has been in the past like really expensive. Like some of these treatments were like costing a lot of money to be trained on, and we don't have those like training manuals and things kind of like floating around just like the other disorders, neurodevelopmental disorders. So, because of that, I think a lot of the clinicians or a lot of the parents have been kind of like left with not a lot of options other than the more traditional, maybe behavioral treatments that can be utilized, but that is not specific to FASD. So that's why I wanted to talk about this one that's called the PACT curriculum. It's one of the 4 evidence-based treatments that is for FASD that's developed by Dr. Chasnoff. And some of you might have listened to Dr. Chasnoff in one of our FASD annual forums, or maybe in another platforms. So this was published in 2011. And the goal of the program is to improve self-regulation. We know that children with FASD struggle immensely with dysregulation. They are dysregulated behaviorally and emotionally. So this program teaches them how to calm themselves down and how to understand that, having that awareness regarding their dysregulation. Second, it targets emotional awareness. Children with FASD, we're not saying that they cannot detect emotions. They can, but most of the time they struggle with knowing when they are scared, knowing when they are sad, happy, and so forth. They live the emotion. However, they might not be as aware about it as to what it feels like. Therefore, they can get easily emotionally dysregulated. The third thing is self-esteem. Most of the time, a lot of the traditional treatment programs really focus on behaviors, like problem behaviors, right? They're aggressive, they don't listen to instructions, but then we don't really look at the whole child. Um, Oftentimes, children with FASD, they struggle with low self-esteem because they understand that they have something different going on, because they don't learn the same way, they don't think the same way, they don't behave the same way as their peers. So this, and then they get a lot of negative feedback from either caregivers, teachers, and others. Therefore, we need to make sure that we target their self-esteem and move it up, and making sure that they develop healthy self-esteem. And then the fourth one is executive functioning skills. Again, in my first presentation for here, I talked extensively about which executive functioning skills that children with FASD struggle with, but mainly things like planning, organization, time management, setting a goal, keeping goal directed, and all of these things are really big struggles for individuals with FASD. So this program also teaches them executive functioning skills. The premise is that we want the children to use their own strengths to learn how to compensate. Because this is a brain-based disorder, we cannot change the brain, but we can create new connections. And then we can teach them how to compensate for the areas that they struggle with. And potentially, when we say potentially, because this is a long road, we know that, right? For anyone who cares for an individual with FASD knows that this is not an easy fix solution kind of a thing, but potentially improve specific areas of difficulty. And we know that children who have been exposed can be taught. So, because sometimes I get this question like, should we even try this? Because will they even learn? Because their brain has been compromised. What we know is that brain is what we call plastic. Plastic, not the regular plastic, but plasticity means that brain can develop new connections. And there's always hope for that. And that is actually true thing for everyone, not just for our children with FASD, but everyone's brain can improve. So they can be taught strategies to compensate for the areas of their deficit, including memory exercises. We can provide the visual cues, scheduling, and having the parent act as an external brain. So we need to teach them how to self-regulate. Then we need to teach the parents that the extensive impact alcohol has on the brain, with the hope that they will understand that the underlying cause of their child's behavior is not willful. The behaviors are not willful, they are not deliberate, but that is because there is a brain-based disorder. And one of the most challenging aspects of raising a child with FASD is determining which behaviors are due to FASD. And please maybe put a comment on this one if you have worked on this area. Which behaviors are due to FASD, like they can't, and which behaviors are they won't, like that they are doing it more because they're being difficult, or they're being a typical 3-year-old who wants to act out, or they want to become a teen, they're a teen who's acting out because they are teen, right? So this is the really hard part, and we work with the parents to differentiate and say like, yes, this is due to FASD, let's compensate for that, right? Let's not punish them for this, let's not put maybe consequences for that. But then there are some behaviors that we can maybe try to change, right? So as the parents learn about the impact of alcohol, the hope is that they will go one step closer to making that distinction. So we know that there is no like cure. There is no cure for really like literally any other thing, right? In our mental health field, like we can teach skills, we can make people feel better. It's the goal is not necessarily just cure, but just to improve their lives and the quality of life. But the strategies that are included in the curriculum will benefit both the children and the families. So, how do we go about teaching through this curriculum? We teach them by not explaining and through didactics, because didactics is not an effective method. So if you have a child with FASD, just telling them what to do is not going to work, which is what we call declarative learning. Declarative learning is learning by listening and instruction versus what we call procedural learning. Procedural learning is teaching by showing something to the child, teaching by doing it together. And children with FASD learn best through doing something, muscle movement, balance, and coordination. This is the way that they can memorize, and this is the way that they will not forget what they have learned, because we have that issue of forgetting, right? So, we also need to teach them problem solving skills, because a lot of the times the reason that they act out is because they cannot reason well, they don't have good problem solving skills. And to be solve a problem, first of all, they need to be aware that there is a problem, right? A lot of the times we ask them like, this is your consequence, do you know like why you got this consequence? They might say like, I don't know. So they need to be aware that, oh, I hit my, sister. That's why. So they need to be aware of the issue so that they can solve a problem. So we need to teach them problem solving skills. But if a child is hyper aroused, like they are like too up, right? They're dysregulated, they cannot solve a problem. This part of the brain and the front part of the brain that solves a problem are not communicating with one another, right? So therefore, we need to teach them regulation skills. So once they are regulated, then they're able to engage in better problem solving skills. And then the last strategy of the PAC curriculum is that our brain filters information based on three rules. We learn by connecting what we learn to our past or known experiences. For example, you're learning something new today. How will this information stick in your head? You might say like, ooh, I've seen this child with FASD and that child had this issue too. So yeah, maybe I can use it in that example or that client. Or if you have your own child with FASD, you might say, yes, this is something I've experienced with my own child. So you trying to relate what you experienced with the new information. This is exactly how we're going to try to teach our children with FASD too. We're going to be we're going to teach something, then we're going to build on the next information on something that we have already taught. Okay. And then the second one is creating interest. If children with FASD, they are interested, if we can pique their interest, then we can make the information stick in their head. And it has to have emotional significance, meaning that this is something important for them, right? So these are some of the ways that we can try to teach our children. So that's why we're going to try to connect new information to existing information. And then how is information organized? When we organize information, remember I said that they have a hard time categorizing information. So we're going to try to categorize the information for them. And that's going to be through songs, rhymes, movement, and other kinds of activities where we want to make sure that the information is categorized in a way that will stick in their mind. So what are some of the theories behind the PACT curriculum? The PACT curriculum is derived from traumatic brain injury work, where we provide psychoeducation and support, cognitive therapy, and executive functions to the family and the client. It's also based on dyadic work, like attachment work, relational therapy, and attachment, because attachment is gets compromised prenatally. It starts that way, and then for children who are separated from their birth parents, right, they are put in the system, and they already again experience attachment issues with their new caregivers, and therefore we need to work on that attachment. The third one is on self-regulation. Anytime there is dysregulation, a child cannot learn. That's period. So body awareness and sensory processing is very important. And then the last one is we need to decrease the stress of the parent and the child and increase their competency as a family system. So the packed curriculum is 12 weeks, each of them around hour and a half each session. This was created for ages 6 to 11, but I've had a lot of questions to say, like, can this be also used for upper ages? Yes, but with some modifications at this point. It needs to be implemented by 4 to 5 therapists. At least one therapist must be master's level to supervise, have license. And then the other clinicians working with the parents can be bachelor's level, they can be a doctoral student, interns, postdocs, others. So we don't need that higher level once we have that master levels who supervises. So we do children sessions and parent sessions separately. And then at the end of each session, the parents and children come together in the last 15-20 minutes. They come together and then we summarize the session together. We do activities, and that's a time when we try to create that bond and foster that relationship. So each children's group session, which is 15 minutes, is spent reviewing information from previous weeks, and we introduce the current week's goals. Then the remainder of the session, around 45 minutes, we focus on activities with the children, lots of hands-on activities. And then the final 15-20 minutes is merging the parent group and the child group. And then we review assignments and we practice activities together. So we need to have 2 separate rooms for these sessions. So in the remainder of our time, I'm going to try to give some examples of some of the activities for the children's session and the parent session, just to give you some ideas as to how these are done. So for children's session 1, we start out by getting to know one another and then forming that sense of group cohesion. We introduce the curriculum, like oh, there's going to be parent sessions, children's sessions, and what skills we're going to be working over. And then we talk about the group rules, of course. And then we on this one, we kind of like start to talk about the concept of the analogy of a car engine. So this is a big concept in this treatment. And then the reason is that we compare our brain to a car engine. And then we say that just as a car engine has different speeds, so can our brains and bodies. So we can be running low in the engine, right? Or in our bodies, or we can be in a high gear, like really, really, really high and very, very active, or the engine is really going really fast. The car is going whoom really fast. And a lot of the kids like this. Or the car can be going just right, or our bodies can be just right. So we start by teaching the concept, taking this like self-regulation. I mean, kids, especially kids are with FASD, they have a hard time with concepts. So what we're trying to do is take out a very abstract concept of self-regulation. We're taking out from the brain and making that very concrete with car pictures, engine pictures, and so forth. Okay, so we do some activities to start out with. So first of all, we have a nice, and I put it down so you can just watch it too, but it is a really, nice song that kind of like goes really, really fast, and then it slows down, and then it goes like fast in increments, and it's kind of like a really fun thing. And then there's always going to be songs, rhythms, and some activity in our groups when we are working with children with FASD. We cannot do talk therapy like the way we know it, okay? And then we introduce the session by playing a clapping game. So I'm gonna tell you a little bit about that. This is always really fun. And this one really also helps with their memory. So what we do is we say something like this. So I say, for example, I start and I say, and I clap my hands. My name is Gökçe and I like flowers. Okay, so the next person repeats what I say and then they add theirs. So let's say the next person is Mary and they say first, her name is Gökçe and she likes flowers. My name is Mary and I like cats. So now the third person has to repeat all of the other and keep those in mind. So this is working memory, right? The one that we talked about. Even through this introduction game of clapping, there is rhythm. Rhythm helps with memory. And then we're working on working memory skills. And it also creates a very nice bond in the group because now we know about that Gökçe likes flowers and Mary likes cats and the other person likes candy. So everyone kind of like starts to get to know each other. So it's a very nice also icebreaker kind of like activity. And then at the end, we can say, I really like, how I ask you to say your names and something you like, and you all did it. Great job. And if they struggle, we do help them. In this program, there is no like, if they struggle, we are there for them. And all we want to do is reinforce, reward, and assume, competency. Okay. So, and then we do a collage for an engine run. So we kind of like have a poster, and in the poster we have them kind of like have like different magazines, and they cut up different things from the magazines, and they say, "Oh, can you please find an activity in these magazines that are high gear, like someone maybe picture of someone jogging, right? That can be that." So and then everyone engages in that. They try to find it from the magazines, they cut things, they glue it, and we have a huge poster board where they kind of like say, this goes under high engine, this goes under high gear, this goes under just right, this goes under low. So by engaging with their body, by cutting and doing it, they start understanding this concept. And in all of these sessions, we always have a snack. Snacks, as we introduce them, help us to change gears. So and of course, with parents' permissions at the very beginning and checking for all allergies and things, consider that we've done all that. We introduce a crunchy snack. I don't know any of you, but like when I get bored in a meeting, when I was working as an academician, we had 3 4 hour meetings. I would always pop up some almonds because that crunch, that kind of like would get my attention back to me, and then so I could just not like doze off or anything like that. So we introduce a crunchy snack, and we say that crunchy snacks, when we are about to kind of like maybe doze off or anything like that, it gets us to just right gear. So now everybody gets a snack, and then we say, how are you feeling now? Show us your gear. And then after we eat the snack, we say, now how is your engine running? So now we keep on and adding on and adding on the same concept over and over again. And then at the end, we end with the song activity again. We walk around as like robots, or and then we slow down and then we speed up and things like that. And then the parents come at the very end. Everyone finds their own parents, which is a very nice, way for them to reunite. And then we do a group squeeze, which is everyone holds their hands. We start gently, and then you squeeze the hand of the person right next to you, and then the next to it, the next to it. Instead of like high five, we're done, and like we do a very nice, gentle group squeeze. And then the reason we do the group squeeze is that for them to have that body awareness, like, okay, I did my squeeze, I'm done. It's the next person and the next person and so forth. So everything is just embedded in the same structure that I kind of mentioned you. So the next session, the second session, is now continue to build group cohesion as well as group members begin to understand their individual differences, which is important in promoting healthy self-esteem. So we talk about self-monitoring and how we can change now engines, right? So we can talk about like, okay, when you wake up in the morning, how is your engine? When you go to sleep at night, how is your engine? When you have a walk at the park, how is your engine? And then everyone gets up and does an activity, show, model, as to show me an activity where your engine goes high. And then they go around the circle and everyone does that. Okay. So In this one, we of course review what we have done before, and we also introduce fidget toys here as an activity. So we have things like straws, silly putty, candy, bendy toys, or stress balls. So those are all things that they can squish, that they can move with their hands, okay? And then we tell them, like, everyone to pick one of those fidget toys, and we tell them, after you play with them, how is your engine? So these are all teaching self-regulation skills. And then for them to be able to make a good decision when they're feeling dysregulated, now they start learning that they can pick up a fidget toy, they can do an activity to slow themselves down. If they're starting to doze off and lose focus, then they can do things like either to get some kind of food. So this is all that idea that they are the agents of change. Parents don't have to remind them to settle down, slow down all the time, that they can actually learn how to navigate their own bodies, right? And then another focus of this session, as we said, is the self-esteem. So what we do is we play a spinner game. And in the spinner game, there is this round thing, and then you can even create it yourself. It says, something I know, likes, the chores, mistake I've done, an animal I like, talent, and dislikes. So, and then when we make this spinner, and then everyone takes a turn and spins it, and let's say, it is a like, okay? And then when it's your turn, the group member tells something that they like. They might say, like, I like cooking, or something I know, I can whistle, mistake I've done. Um, they could talk about that. And then they say, oh, animal that I like sloths, all right? Dislike, I dislike packing. So this way, the group members learn again something about each of the group members, okay? And that kind of like helps out with creating that group cohesion. And then the children here really understand that everyone has something to contribute, because this is not the message that they're getting outside. A lot of the time they might get bullied, teased, left out, and so forth. But this is in this group, this is where they are being valued for who they are, whatever they bring in, and with all of their qualities. And then at the end, we do a puzzle tape, which is um, we get like huge papers, and then we put like random puzzle sections on it, and then we cut them up, okay? And then we tell, yeah, and then we tell each of them ask this question: how are we the same, and how are we all different? So we ask them to write, how are you same as the other person? They might say, I have blue eyes, they have blue eyes. But then also, how are you different from your friend? So they write about their differences. They might say, well, I'm not good at math, or I'm not good at reading, like, or I wish I had a sister. So that's how I'm different, because I'm the only child. So everyone writes something that they're the same and different. And then at the end, we put all of those puzzles together, puzzle pictures. So it also helps them kind of like put the puzzle together on the floor. It's like a huge activity. So we need kind of big rooms for these groups. And then when we put it all together, we say that now we're like a big family with all differences, but lots of things that are similar as well. This is again a very nice way to create that group sense of belonging. Like, I belong somewhere, and I belong to in a group, and I have things that are similar to others, but I have things that are different from others. But this is the beauty of it. So this again, working on fostering that self-esteem in this activity. And then session 3 is, now we try to teach them specific tools and strategies to use at home, and monitor their speed engines. So this is a really fun session. We make the engine I have a hard time saying this word, speedometer, yes, to take home. So it's like this, made from a carton and then cardboard, and then it's like this half circle shape, and then we have some little gadgets to put in there. They divide it into 3. Everyone makes a color. When I give these trainings live, like, face to face, we make this together so that you guys all all learn like how to do it specifically. You can do it in like paper plates even. So we divide it by high, low, and just right, right? And then they color it in different colors. Like maybe for one child, feeling really, really high is like red. And then feeling like just right is green. Maybe like feeling low is yellow, right? Everyone makes a different color. And then they can use it in the session and also at home. Like if your child is really struggling, you could say like, please let's do your speedometer and see like where you are. Like, how is your engine running? Okay, let's see that. And then you take it on and say like, how do you think your engine is running? They say like, I use it for in therapy all the time with a lot of my kids, regardless whether they have FASD or not. And they say like, I'm running a little low. So, okay, what can you do? What can we do from the things that we have learned? Okay, so we just build on to the same thing. You might just say like, enough with the engine running and all of that stuff, but it takes a really long time for those connections to be made. Therefore, we make sure that we emphasize it a lot. And then we give it as homework, and then we want them to put in activities that help them to lower their speed or increase their speed. So they give a homework assignment and we explain it to the parents. And then together, when the parents come in and join, we do a relaxation exercise. We have a script that we go through. Everyone lays down on the floor. It's really fun. And then we can say one way to settle down is we can do these relaxations at home together. And that can be recorded, so you can just put it on. You can put it on your phone, you can do it, read it yourself and put it on the phone, and you can do it together with your child and say like, I think you are at red right now, your engine is running really high, so maybe let's put it on our song to calm down, or let's do our relaxation together. So we make the engine speedometers draw themselves doing an activity, and then the joint relaxation exercise. And then in session 4, we play a slow down song. Again, we are building on these skills. We repeat our relaxation again, and then we review our homework from the last week. This is a really nice wake up song. So let me see. Yeah, I put the YouTube in here. In this one kind of like starts out really like slow and then shows like how we can kind of like start our day, because sometimes for our kids with FASD, waking up in the morning, getting ready for the day is really, really hard, but also settling down is really hard. So this is a slow down song, and we talk about like how to slow down using this song. Then we do an obstacle course. Remember, we said movement is really important in teaching our children with FASD. So in this one, we have to have things like a hula hoop, things like doing jumping jack, and then those, gym, in the gym, the kids kind of like crawl into it. We can have some of those, any type of gym type of activities, or like gadgets that we can have, and then we make an obstacle course. I mean, it can be done in like with pillows and like things that are not very expensive. Okay, so we have them go through the obstacle course really, really hard, like, and they love it. They just absolutely love this one, because that's when they can be hyperactive. So they go through the tunnel, they do the hula hoop, they crawl, they jump on from the pillows, they do like turns, and then they do jumping jacks, and of course their gear is really high, right? And then we say like, how is your engine running? Like really, really high. And then we put on the slow down song and say, what can we do to get our engine down? And then we do the song, and then we can do some treats as well. So any treats that are soft in the mouth, like yogurt, any of those things, those kind of like don't require us to chew that much, they slow us down as well. So those type of things. And then the other things that are crunchy, like carrots and cucumbers or almonds or anything like a crunchy like cereals, they kind of like help us to be more alert. So we can talk about the different types of foods that help us to change gears. In session 5, now we talk about planning and executive functioning skills. This is a really fun one too, because this is a deficit area for our children to plan and think through the steps. So we go around and we make all the things available for having a peanut butter, jelly, bread, and then we have a plastic knife. Okay, you need to probably get a peanut butter that is soft and it's easy to spread and hasn't been like stuck like that. So we go around and ask each child how to make peanut butter and jelly sandwich. And then we as the clinician do exactly what the child says. Usually children say something like this because they are not detailed enough. They say, you take the bread and put peanut butter on it. So what we do is, let's say this is bread, okay? And then we take the jar and we put it on it like this. We pretend like, okay, like this is how it is. They said, no, that is not like that, silly. And we said, so tell me exactly how to do it. So here, what we're trying to promote is that step by step execution of any task is detailed, has steps in it. So I say like, okay, so tell me what to do. Okay, put it down. Okay, take the bread. Then we take the whole loaf of bread. The whole thing? Said, no, just take one. Okay, so how am I gonna take one? It's not even open. Then we say, you need to open it first. Now they get the idea. Now the next person tries it, and then the next person. And then we help each other out. So it's almost that the other child tells the other one, you need to untie, and then you can take it out. Oh, all right. So this, everyone takes a turn and everyone tries to now make a better job of, what the other person maybe struggled with. So it almost becomes this very nice group activity. And just make it fun. Like, we're not trying here just to teach them exactly how to make peanut butter and jelly, but this is more for them to understand that things and tasks have steps to it, and we need to do it step by step by step. And then there is a homework for the week, and there are many different things on the curriculum that says, with go to a restaurant and order food, right? This is a really important thing. And then I want you to write down all the steps that you did while ordering food, okay? Or when you go home, make a sandwich, with your mom, or tell me all the steps that goes into brushing your teeth. So we give this homework, and then the parents are supposed to help them out doing this together. So this is promoting executive functioning skills and learning sequential activities. Now in session 6, we are shifting to another skill, which is called emotional awareness. We're still working on the engine. We're still working on relaxation. We're still working on self-esteem, okay? But now we're adding this emotional awareness part into this skill. And then in session 7, now we are starting to move to more self-esteem, okay? And now that we have established that body-mind connection, and then they're able to, in session 6, I didn't go over as much, but we talk about emotional awareness and different types of emotions. There is a whole script around that. But that's something that maybe a lot of you have tried in your sessions or have worked through that with your children. It's not as very different, but it is more that creating that emotional awareness. And then on session 7, we talk about, like, again, the feelings, and we discuss feelings, and everyone comes out with different feelings. And then we do a body map, like the body map of like where we feel different feelings. When we feel sad, where do we feel it in our body? Everyone colors it. And it's, again, combining that abstract concept with something that is experiential, so they can exactly understand how that feels. Okay. We still go on with the high to low of a gear, high of a gear, and so forth. And we keep on working all of these concepts as well. Let's see, on session 8, we continue to work on feelings, and we do the activity of feeling charades. And everyone now does the feeling charade of like acting one feeling, and then the group members try to understand what is the feeling that they're trying to explain to the other person, guess. And then we do this activity with the parents so that parents can also try to understand their children as well. And then in session 9, now we try to get into the concept of self-esteem. We describe then what a self-esteem is, and then we say that everyone is good at some things and not great at other things, and this can affect our self-esteem. And then what other people tell us, how they talk to us, impacts how we feel, right? So we talk about that. And then we get some paper plates, because this is a hard concept for children in general, and also with our children with FASD. So we get paper plates, and then we say that I want you to put on the inside of the plate how others see you outside. Okay? So, I'm sorry, on the outside of the plate. So let's say, do others see you as like, a very active child, or like do they think you're a happy child? We give some examples, of course. So everyone draws that. And then we say, now turn it inside. And in the inside, I want you to draw how you feel inside. So we give a lot of help with that. Okay. So this is really striking, because we get a lot of tears in this one, a lot of difficult moments that we need to process as a therapist. It is that everyone thinks I'm this and this and that, but inside I'm really feeling this way and that way. So here now we can get into feelings, we can get into the lower self-esteem and how they truly feel about themselves. Okay. And then in the next one we talk about what we call Mr. Mean. Mr. Mean is our inner voice that really criticizes us. Okay, and then we give lots of examples. Our Mr. Mean tells us that we're stupid. Our Mr. Mean tells us that we can't do this. Okay, so we want them to write down and first of all, draw Mr. Mean for each of them, and then to write down on the paper one thing that Mr. Mean tells them, and then one positive thing that we can tell Mr. Mean, so that we don't have to follow what Mr. Mean says. Okay, so we're trying to now help them understand how we can do positive statements about ourselves, and how we can balance it out, the negative messages with the positive messages and positive thoughts, and how we can replace those thoughts, the more negative ones, with the positive ones. So this is also a very impactful session there as well. And then children's session 11 is now we teach them to praise each other, and then say something nice about the other group members, right? Because it's all about how we also treat other people. So we ask them to write one positive thought about each member of the group, and make a box for each person. So every person makes a box for themselves, has a little slit, and then everyone writes something positive about that person, and everyone keeps it in their box. And at the very end, they will open it up, which I'll talk about. And then we also invite parents, and we ask the parents to write 3 positive things about their child. Sometimes that can get hard to find 3 positive things, because they're so used to focusing on the negative part of it, right? This is the last group session that the children will spend together. So the focus is on saying goodbyes and bringing closure to the group. And it's all about practice giving and accepting compliments, and talk about what it is like to hear good things about themselves, right? And then the 12th is the final session. This is a goodbye session. In this one, we play a Family Feud, a quiz game, which is really fun. It's all about the things that they have learned. So, and then they can just earn rewards, but at the end, everyone earns rewards. Then we have a graduation ceremony where each kind of get a certificate. And then we also give them, like, there's like some cake or ice cream, whatever they would like to do. And at the end, we do what we call a friendship web. We have a yarn, and this is a really nice one to do in any group session. And then the group leader starts with the yarn and throws it to one person, says like, okay, Mary, and then says something nice, one nice thing about Mary, a compliment. And then Mary holds the other part of the yarn, and you still hold that one. Then Mary throws it to the other person, so it becomes like this very nice web, and at the end everyone holds on to it, and it becomes like this web. And we say, like, now we're connected all together through this web, and now we're all friends. And this is how kind of like we end our sessions. So I know we have a few minutes left. I want to go through very quickly over the the parent sessions. So parent sessions are more psychoeducation. So we provide lots and lots of information, the ins and outs of what FASD is, everything about the brain, the symptoms, and how we see FASD in the daily life. So session 2, 3, and 4 are all about that. And then the parents can ask as many questions as they like to the group leaders. Okay. And then, yeah, this is teaching parents better ways to manage children's behaviors. And in this one, we teach the parents, we teach them how to be an external brain. And we teach them that the children's behaviors are not bad and they're not intentional. And then we give them a lot of strategies for home, how to have a structured home with low levels of stimulation, predictability, routines, reviewing daily routines, very clear expectations, having plan B for problem behaviors, especially in the public or during transition times or in holidays. Then we give more strategies for home, helping them kind of understand how we can de-escalate behaviors, and when the children become overwhelmed, what to do. Then we give some strategies for school, because a lot of the times parents are asking for strategies like, the teachers don't know what to do, the principal doesn't know how to handle my child, what can we do? So we give some specific recommendations for how the school staff can be an external brain for the child at school. So these are like some specific strategies. Then we go over memory strategies to employ at home. Some of those I've talked about it throughout my presentation. And then we teach the parents the whole problem solving approach. And then we want them to implement it at home with their child while we teach the same skills to their children in the children's session, right? And then we teach families, caregivers, how to give directions for their children with FASD. And then we teach them discipline and strategies, like let's not, we can ignore some of the behaviors, but we need to avoid punitive consequences. We need to provide a more cool down area where they can have some sensory, toys with them. And administering the consequences, not big, like, I'm going to take your computer for 2 weeks. No, that's not going to work for a child with FASD. Administering them in small doses and giving them a lot of time to process and understand the cause and effect. I'm taking the phone away for 2 hours, and 2 hours is going to end at this time because this happened, and then move on to the consequence. And only discuss the behavior and the cause and effect when they are calm and collected and ready to hear the reason. Then we talk about de-escalation, how we can do that, how we can provide this calm down area, what needs to be in the calm down area. Then we talk about some educational supports with the families. And then we also talk about, when you go to a psychiatrist, how can you talk about your child's struggles so that the psychiatrist can prescribe the best medication that fits your needs? Because sometimes what we see is our children are on 4 or 5 different medications, and that's a disaster, really. And that's because the psychiatrist has not been able to assess really well. So we tell them, like, does your child's biggest struggle in the behavioral domain? Or is it the hyperactivity? Or is it because they're very dysregulated? Or is it more the aggression and not following directions, right? Then the doctor can kind of like cater the medication according to these 3 areas. And we have a whole session that we talk about this medical piece. And then we talk about the parents' mental health too. the parents' self-care. We do a whole session on self-care, how to do self-care, decreasing parental stress. And then we do a session on if the children need to be referred for occupational therapy, what is that about, and how can they advocate their children on occupational to get occupational therapy. And then we talk about this low self-esteem concept with the parents too, and how we can more improve our self-care. And we talk about a self-care plan with the caregivers, which I think is really nice. And we talk about self-care exercises. We do a whole plan. And then we do the similar activities with the parents, because parents also have very negative comments about themselves too, because they're really struggling. They're really struggling in the parenting area. And we talk about how they can nurture a child's self-esteem. And then we also talk about how to take your child to a pediatrician, what are some of the common questions that we can ask about their health, and how to make sure that you keep the health of your child in check. And then this is an opportunity to do catch on all. And then the last session is when we reunite and then say goodbye with the group. Okay. So I put some information. I'm not going to go over each, but what are the role of the group leaders if you would like to maybe do some of these groups? Who needs to do the parent group? Who needs to do the child group? And then some of the tips and tricks for making sure that the sessions go smoothly. And I put down some of the materials in case you want to replicate some of them. Put some of the materials that were needed. And at the end, I put some resources for our Ohio Moss webpage where you can get tons of information. I have like several trainings here. Like if you feel like you don't have the beginning part of the training that I provided to the Kinship Coalition here, then you can have those trainings, and they're all for free on the website. You can find those. I have very short videos. We have double-sided cards. We have wealth of information. And then we used to have just 2 diagnostic centers. Now we have one in Cleveland Clinic by Dr. Lipman. I do not have the link up here, but you can go directly to Cleveland Clinic, and then you can find Dr. Lipman's diagnostic center. So now we have 3 diagnostic center if you need to refer or take your child for an evaluation for FASD. And then I put also a link for a screening tool where you can kind of utilize, and once you feel like that there are enough red flags, then you can also refer for an evaluation, both for your child or someone that you're caring for. All right, I think then this is the end of my presentation. Now I close it up. I can maybe try to see any questions. And then I think somebody's asking for my contact information. I am just putting it down on the chat here. And please feel free to email me here from here. And I'm very happy to, send you resources and consult and things like that. And we can be in correspondence from there as well. So just wanted to see what questions we might have.
I know Dr. Dr. Ergun, there were a couple of comments. One of the individuals commented that she, after you've gone through some of the descriptions of identification, she thinks that somebody that she is connected to may be having is more FASD than autistic. And so I think this is a critical point, that the diagnosis to differentiate from other conditions is really important.
Yes, it is. And then if again, maybe was it Jamaica? There is a training that I've done on diagnosis where I talk about differential diagnosis between autism and FASD and so forth. If you're able to find that, I think that's going to be really helpful and impactful. And also maybe using the link for the screener that I put in there, then that also screens for more FASD features and symptoms. Maybe that can be an impetus, kind of like a way to kind of get to some of those diagnostic centers, maybe going through that screener as well. And I have more thoughts too, obviously, but just for the sake of time. But feel free again to email me if you would like to know some more specific ways to differentiate between autism and FASD, and I'm happy to help.
We will post, if you're willing to give us the PowerPoint, we will post that on our OGKC website as well as the recording. So we provide both of those pieces of information for people to, I mean, this was tremendous. It was a lot of information, but you've done a great job presenting it. But I know people, it was a lot and would like to go
Of
back,
course.
and I know I would.
Yeah.
So we'll post those on the website.
And do you have the first one too, the one with the red
Yes.
flags, the symptoms?
Yes.
Yeah, because
Uh-huh.
maybe for
The
those
initial
who,
one.
yeah, the introductory one. Maybe it would be nice for those who might have missed that one to first view that, look at the slides, and then and then maybe followed with the treatment, because this is now part 2 for that part now. Okay.
Right.
And I have a question. I think I can now see the chat. How do you start the process of a diagnosis? We have a 2-year-old. So I know that 2 to 3 years is like when we kind of like start the diagnostic process. Okay. So one thing is that I think once you call the diagnostic centers, they might have different thresholds, like different ages for when they start diagnosing. I don't know it on the top of my head, but once you call them, they will kind of like inform you. And as to whether that 2-year-old is too early, maybe need to wait a little bit, and so forth. But I do have I've developed a screener with one of my students that we're trying to pilot. It is not out there yet, but I can send you some of the questions, and I've developed one for 2 to 5 years of age, like for the younger ones. And I'm kind of like happy to share some of those questions with you to see and then you can go through it those yourself, and to see if you're seeing a lot of those, and that can kind of maybe prompt you as well, or directly call any of these diagnostic centers and ask the intake specialist, is 2-year-old a time that we can start this diagnostic process? Okay. Hi, Sandy, then. And yeah, I know I've done tons of trainings and so forth. And yes, I've done a lot at Dayton Children's. So nice to, come across again. All right. And I'm going to try to see. And Darlene, you said my grandson needs his treatment and he's 9. His mother was drinking and using drugs. Yeah. I think 9 would be a perfect age for what I've explained. Kind of like going through this program. And one of you said, Laverne said, lots of information to give to the families in the group. That's very nice. And let me see, any others at the end? Dayton Children's is not a diagnostic center at this point. There is the genetic department, so maybe you can start there, and then just get the genetic part, the medical evaluation. So, and I know this is not the scope today. I'm talking about treatment, but again, in my trainings, I talk a lot about the diagnostic process and what it looks like, and I'm happy to talk about it with any of you. More specifically, yes, definitely. Feel free to reach out to me. Yes. Through my email as well. But in the diagnostic process, there are 2 parts. One is done by the psychologist and a neuropsychologist, and that's a series of tests, psychological tests, more like neurodevelopmental neuropsychological tests. And then the second part of the evaluation for diagnosis is through what we call a medical evaluation done by either a geneticist, right, or by a developmental pediatrician, where they do facial measurements, just making sure that this is due to prenatal alcohol exposure. And then they look at the height and weight, and then the head circumference, and they have specific measurements. And then the doctor's report gets put together with the psychologist tests and evaluation, and then the clinics usually put it together, coming up with the diagnosis after they also look at a lot of medical records. So if you are on the brink of having an evaluation for your child or for someone that you care for, getting all of those medical records is very, very important. Also, child welfare records, that if they have been in the system, it's really important that you bring like all of those records, because there they will probably want to know if there was prenatal alcohol exposure. And that's the only way that a child can get in a diagnosis, because we need to have some kind of evidence somewhere in the records that there has been prenatal alcohol exposure. And that's one of the most important, criteria. Okay. All right. Let me see.
Well, I think that everybody has stayed on
Yeah.
the Zoom meeting. So that tells you, that gives you an indication of how important this was. And so hopefully, again, we'll post everything that we have on our
Yes.
website, as well as the previous one is on the website under
Yeah.
resources.
Yeah.
And I would like to announce the gift card recipient for this meeting is Melissa Jordan. She is a caregiver from Auglaize County. And so we welcome her. I don't know if she's been on before. I don't recognize her, but we're glad she's joined us. And I see a number of new names, and I see a number of older names that have joined us. So thank you very much. If anybody has any other questions, you can obviously email me or email Dr. Ergun, and she obviously has opened herself up to interacting and answering questions and giving you more information, which is very helpful. So anybody else have anything else that they would like to say at this point? Well, a lot of indication that people valued this information, and I think you'll probably get some follow-ups after this. So
Definitely.
Thank you for being willing to do that.
Definitely.
So
I love a whole good consultation and questions. I have tons of resources. So, and then as I said, the Ohio Must webpage that will be in my slides that you will post has tons of information. So please make use of them too. Yeah, and I have from Melissa, my first time, we have 6 kinship ages. Oh, that's wonderful. 2 to 14, very relevant there. Yeah. Okay.
thank you.
Thank you, Jamaica,
Um,
everyone.
well,
And thank you
yeah,
for all listening too, and being here and showing up here. I think that's wonderful, and that's very important, and that's an indication that you're here to keep learning, help, and be helpful to others. Thank you again.
all right. Thank you, everybody. Everybody have a great day, and continue to do the good work you're doing and helping the children in your care or children that you work with. We appreciate it very much.